Welcome to the Healthcare Unfiltered Express, where I conduct short video interviews packed with relevant and timely information that you cannot miss. So sit back and enjoy the show. Healthcare Unfiltered Express, Dr. Professor Virginia Kaklamani, welcome. You know, you're my junior fellow at some point, but you're the smarter one of the two.
I don't know about that, but yes, I was your junior fellow for 2 years.
Well, welcome to Healthcare Unfiltered Express. Really happy to have you, Virginia. And, this is the express version of my podcast. And really what I want to cover is CDK4/6 inhibitors, partly because there are several of them. And we're going to try for viewers and listeners to simplify selection and where they apply in metastatic disease and in the adjuvant setting in breast cancer. So let's start with metastatic disease. Maybe give us a lay of the land, how many of these there are, and how do we actually make a choice?
So 3 approved: palbociclib, ribociclib, and abemaciclib. All of them approved in combination with endocrine therapy, either an aromatase inhibitor or fulvestrant. All of them having met their primary endpoint with a hazard ratio that's almost identical between trials. Ribociclib is the one that has consistently also showed an overall survival benefit. Abemaciclib did in one of the trials, just missed the mark on another trial as well. So I think most of us are going to think in the metastatic setting that ribociclib is probably the better one, but that may not be extremely fair just because all met their primary endpoint. Difference in toxicities. So with palbo and ribo, a little more cytopenias. With abemaciclib, more diarrhea. With ribo, we have to do an EKG and watch the QTC and make sure that drugs that are given with it are not also extending the QTC. We also have to manage LFTs and monitor them with ribo. So those are really the differences. But honestly, I think you're justified giving any of them in that first or second line, depending on when you decide to do that.
So none of these CDK4/6 inhibitors in metastatic disease have demonstrated survival benefit today.
So ribo has in 3 of the trials. Abemaciclib has in 1 of the trials. OS is always a little bit of a question mark as an endpoint, because yes, of course, it's the holy grail. We'd love to see OS benefit, but at the same time, it's so dependent on post-treatment or post-trial treatment, which is not controlled by the clinical trial. Some of it has to do with how large the trial was. And so with abemaciclib, the trial that did not meet the endpoint, the OS endpoint was probably because the trial wasn't big enough. It wasn't powered to look at overall survival. But if you're thinking of, yes, I want a consistent overall survival benefit in clinical trials, ribociclib was the one that showed that.
Are there specific phenotypes of a patient that you see beyond, the usual ER, PR, that stuff? Anything else, whether it is on genomics or particular characteristics of the patient, clinical characteristics that might sway you one way or another?
So palbo is probably the easiest one to give as far as adverse events. So if I have somebody who's a little frail, somebody that's a little marginal as to whether I want to give a CDK4/6 inhibitor or not, I'll pick palbociclib. At the same time, if I have somebody that has issues with infections and I'm concerned about the cytopenias, I may pick abemaciclib because it's the less cytopenic of all. But if somebody comes in and already has issues with GI toxicities, diarrhea, I won't pick abemaciclib because it has more diarrhea. So those are kind of things that might sway me one versus the other. For the majority of the patients, I end up picking ribociclib in clinic. But again, if I see a patient coming for a second opinion and they've been on palbo or abema, I will not switch them because I think that's an appropriate therapy as well.
And there's absolutely, there's never a reason to switch to another CDK4/6 inhibitors upon progression of the first one.
So there's a few trials that have looked at switches or continuation. So the bottom line is if you're on palbo and you want to continue on palbo, there doesn't seem to be a benefit. But if you're on palbo and you want to switch to either ribo or abema, there might be a small benefit. And so some patients might get switched to a different CDK4/6 inhibitor. But it's typically from palbociclib to ribociclib or from palbociclib to abemaciclib.
Excellent. So let's move now to the adjuvant setting. This is metastatic disease in the adjuvant setting. And as you describe with the adjuvant setting, I do want you to explain to viewers and listeners if these are chosen in the adjuvant setting, would that affect you using them in metastatic disease? But let's start in adjuvant disease.
Absolutely. So two of them showing a benefit in the adjuvant setting, ribociclib and abemaciclib, and both of them are considered now standard of care, approved for a higher risk patient. So patients that either have node positive disease or high risk node negative disease. Abemaciclib given for 2 years on the standard dose, ribociclib given for 3 years at a lower dose compared to the metastatic setting, and that helps with toxicity as well. So this is, again, considered standard of care. We'll give it to our higher risk patients with pretty good outcomes. What we don't know is if patients develop metastatic disease after having received these CDK4/6 inhibitors in the adjuvant setting, what do we do? And do we re-challenge them or not? And so I think most of us would give a CDK4/6 inhibitor if the time between the end of the CDK in the adjuvant setting and the development of metastatic disease is more than 12 months. But if it's less than 12 months, we likely won't re-challenge them with a CDK4/6 inhibitor.
And to clarify, these are not given as monotherapy. They are given in addition to hormonal therapy.
To endocrine therapy, exactly. So here's also the other little trick. We do not want to be combining tamoxifen and ribociclib because of that QTC prolongation. So if you want to give tamoxifen to a patient, the one that you want to give it with in the adjuvant setting is going to be abemaciclib. At the same time, that's a little tricky because both of these drugs can increase the risk of DVTs. So we have to be a little careful if we're combining the two. So in most cases, when we give endocrine therapy in combination with a CDK4/6 inhibitor in the adjuvant setting, it'll be an aromatase inhibitor plus the CDK4/6 inhibitor. And if the patient is premenopausal, we'll add ovarian suppression.
Does it matter which hormonal therapy you use with it?
Again, we want to try to give an aromatase inhibitor, but it doesn't seem to matter. So in the metastatic setting, there was a trial that looked at fulvestrant versus AI plus a CDK4/6 inhibitor, and it made no difference.
Got it. And then maybe my last question or clarification, what's this pathway CDK4/6? Can you just maybe give us a little bit of the importance of this in terms of what does it do for breast cancer specifically and things of that nature?
Absolutely. So CDK4 and 6 are involved in cell cycle arrest, and that's how they work. That pathway is also connected to the estrogen pathway as well as the PI3 kinase pathway. And so there's kind of cross connectivity, and that's why now we're giving CDK4/6 inhibitors in combination with PI3 kinase inhibitors, and why it makes sense to combine them with endocrine therapy as well. But they do cause cell cycle arrest. We think that the CDK6 is more important than CDK4 inhibition. And but now we're developing CDK4, CDK2 inhibitors, CDK7 inhibitors that at some point we're going to likely give in patients that have developed progression of disease on a CDK4/6 inhibitor.
Okay. My last question, I forgot to ask you this. So in metastatic disease, we often treat until disease progression. But in the adjuvant setting, you did mention probably the duration, because for the hormonal therapy, back in my time, it used to be 5 years. Now it's 10 years. I mean, I don't know how long you continue actually this, but the CDK4/6 is only 2 years?
2 years for abemaciclib, 3 years for ribociclib.
And the hormonal therapy continues?
For 5 to 10 years.
Well, anything else we should know about CDK4/6 inhibitors? Did we cover it all?
We covered all of it, I think. The CDK4/6 inhibitors have helped improve overall survival in metastatic disease to now surpass 5 years. So this is really a game changer. And we started using them in 2015. We've come a long way, and really we've changed how we treat metastatic ER-positive breast cancer because of CDK4/6 inhibitors. So it's been a really good journey.
Such a pleasure to have you on, Dr. Virginia Kaklamani on Healthcare Unfiltered Express. Thank you so much.
Thank you.
Thank you for listening to this edition of the Healthcare Unfiltered Express. Until next time, take care.